Welcome, doctors, to this masterclass explainer on diabetic retinopathy. Now, today, we're not just going to sit here and memorize isolated facts for a test. We're going to build true long-term clinical mastery. We'll be tracing this disease from its microscopic origins all the way to its most devastating, sight-threatening stages. By the end of this session, you're going to understand the anatomy, the pathophysiology, and exactly how to synthesize imaging so you can make board-level clinical classifications with total confidence. Let's get into it.
But before we zoom in on the cells, we really have to look at the sheer scale of this epidemic. 100 million Americans are either diabetic or pre-diabetic. The clinical volume you're going to face in your career is absolutely staggering. And here's the truly concerning part, right? A full quarter of the 30 million patients with full-blown diabetes are walking around completely undiagnosed. Literally, you will have asymptomatic patients sitting in your chair just for a routine glasses check, and you will be the first physician to detect their systemic disease.
So to master this, we're going to follow a 5-part clinical framework today. First, histology and vascular derangements, then ischemia and the VEGF cascade, diagnosing NPDR and DME, mastering the 4-2-1 rule, and finally, high-risk PDR.
All right, let's jump right into Section 1, Histology and Vascular Derangements. This is where we look at the microscopic origins of the disease.
Okay, let's dive into this. This is the foundational pillar of the disease. Everything you see at the slit lamp is anchored right here at the microscopic level. There are 3 fundamental histological vascular derangements in diabetic retinopathy. Number 1, parasite loss. Number 2, basement membrane thickening, which decreases the lumen diameter. And number 3, loss of endothelial barrier function. Now, if you're preparing for the OCAP, I want you to burn this into your memory right now. Parasite loss is the very first vascular derangement to occur. It's the initial domino that sets this entire pathological cascade into motion.
To truly grasp this, we've got to visualize it. Let's orient ourselves to these retinal trypsin mounts. Look at the normal healthy capillary network on the left side there. Notice the darker parasite nuclei wrapping the outside of the vessel, maintaining that really healthy 1-to-1 ratio with the inner endothelial cells. Now compare that to the diabetic retina on the right. The parasites are just gone. That protective, supportive cell is completely lost, leaving us with a many-to-1 ratio of endothelial cells to parasites.
So what happens when those vessel walls lose that crucial structural support? Well, they bulge. These are microaneurysms, and they are one of the classic early manifestations of the disease. When a patient complains of a minor vision fluctuation and you see these tiny red dots on your dilated fundus exam, you are looking directly at the macroscopic result of that parasite loss we just talked about.
Moving on to Section 2, Ischemia and the VEGF cascade. Let's look at progressive occlusion.
Now that the vessel wall is compromised, the basement membrane starts to thicken, which visibly narrows the vessel lumen. This progressive occlusion leads us directly into our next biological stage, ischemia. I want to pause here for a moment of active recall because this is a classic board concept. When that progressive occlusion starves the retinal cells of oxygen, making them ischemic and hypoxic, what specific signaling molecule do they release as a biological cry for help? Take a second and lock in your answer.
If you guessed VEGF, you're spot on. Specifically, VEGF A165. This extracellular signaling protein binds to transmembrane receptor tyrosine kinases to promote new blood vessel development. And honestly, this isn't just an OCAP pearl for diabetes. This exact same VEGF isoform plays a central role in the pathogenesis of wet age-related macular degeneration and central retinal vein occlusion. It is literally the master switch for pathologic angiogenesis in the human eye.
Now, what's really interesting about this slide is how we capture that ischemia clinically. Look at this fluorescein angiogram. Instead of a normal, uniform, hyperfluorescent glow indicating healthy capillary filling, you see these extensive, stark, dark areas of hypofluorescence. That is profound capillary dropout. Those dark regions are completely non-perfused, and the hypoxic cells within them are basically pouring out VEGF. All right, Section 3, Diagnosing NPDR and DME. Let's take this straight into the exam room.
This brings our third histological derangement, the loss of endothelial barrier function front and center, as it creates one of the most common causes of vision loss in these patients. Remember those tight junctions between normal endothelial cells? Well, when the inner blood retina barrier fails, serum just leaches right into the tissue, creating diabetic macular edema. Take a look at this OCT scan.
Instead of a normal compact foveal contour, look at the inner and outer nuclear layers. They're entirely disrupted by these huge, hyporeflective, dark intraretinal fluid cysts. This swelling physically alters the photoreceptor alignment above the intact RPE and Brooks membrane, which is exactly why your patient is sitting in your chair complaining of blurred central vision.
At this point, we need to draw a hard anatomical line. When grading this disease, we split it into non-proliferative diabetic retinopathy, or NPDR, and proliferative diabetic retinopathy, or PDR. Guys, do not confuse these, and please do not be vague about the definition. Proliferative retinopathy specifically refers to neovascularization that is broken through the internal limiting membrane, the ILM. If the new abnormal vessels respect the ILM, it's still non-proliferative. Keep that absolute hard and fast rule in your mind at all times.
Which brings us to Section 4, Mastering the 4-2-1 Rule. Let's talk about classifying severe NPDR.
To properly classify the severity of NPDR, you absolutely must know the findings of the Early Treatment of Diabetic Retinopathy Study, or ETDRS. You're going to use this framework every single day in clinic and on every single board exam. This is the famous 4-2-1 rule for diagnosing severe NPDR. It requires 4 quadrants of extensive retinal hemorrhages, or 2 quadrants of venous beading, or 1 quadrant of ARMA. Listen carefully to how I phrase that. Or. A massive OCAP trap is thinking a patient needs all 3. They don't. If a patient meets any single one of these criteria, they instantly skip mild and moderate and are immediately classified as having severe NPDR.
And this brilliantly illustrates the 4 in our rule, which stands for hemorrhages. Notice that heavy, widespread distribution of dot-blot hemorrhages tracking along the arcades and scattered extensively across the superior, inferior, nasal, and temporal quadrants. This diffuse breakdown easily meets the criteria for severe NPDR all on its own.
Next up is the 2, venous beading. Look closely at that main vein coursing through the image. Do you see how the caliber isn't smooth? It kind of looks like a string of sausages. This sluggish, irregular segmentation tells you the vascular wall is incredibly diseased. If you see this in just 2 quadrants, your patient has severe NPDR.
Finally, the I, intraretinal microvascular anomalies, or IRMA. Now here is a major board trap to watch out for. Look at these tortuous, squiggly vascular loops. They look a whole lot like neovascularization, but let's go back to the rule we established earlier. The I stands for intraretinal. These aberrant vessels have not broken through the internal limiting membrane. Because they respect the ILM, this is still non-proliferative disease.
Finally, Section 5, High-Risk PDR and Prognosis, the most critical, sight-threatening stage.
So what happens when that disease process finally does break through the ILM? We shift our focus from the ETDRS findings to another landmark trial, the Diabetic Retinopathy Study, or DRS. This is where we identify the most sight-threatening stage of all. Once a patient develops proliferative disease, our main concern is determining if they have high-risk PDR. The DRS gave us 3 highly testable cutoffs here. Number 1, any neovascularization of the disc, or NVD, paired with a vitreous hemorrhage. Number 2, a large area of NVD, and by large we mean greater than or equal to 1/4 disc diameter, even without a hemorrhage. And number 3, a large area of neovascularization elsewhere, or NVE, greater than 1/2 disc diameter paired with a vitreous hemorrhage. Just remember the shorthand, any NVD with blood, large NVD, or large NVE with blood. Commit those disc diameter measurements to memory for sure.
Let's move to a clinical example and see how this builds. Orient yourself to the optic nerve head on the left. See that lacy, fragile network of fine fronds sitting right on the disc? That's NVD. And pooling just inferior to it, completely obscuring the underlying vessels, is a massive, boat-shaped preretinal hemorrhage. That combination means urgent panretinal photocoagulation or anti-VEGF therapy is required. These vessels are incredibly fragile, and without intervention, this patient is at an immense risk for severe visual loss.
To wrap up our explainer today, I've got one final rapid-fire retrieval challenge for you. According to the DRS, if you diagnose a patient with severe NPDR using that 4-2-1 rule, what is their chance of progressing to high-risk PDR within 1 year? And what if they have very severe NPDR, meaning they hit 2 or more of those 4-2-1 criteria? Well, the answers are 15% and 45% respectively. That nearly 50-50 coin flip for very severe NPDR is exactly why we monitor these patients so aggressively. So the next time you sit at the slit lamp and see a tiny microaneurysm, I don't want you to just see a red dot. I want you to see the missing parasite, the ischemic cascade, and the soaring VEGF levels underneath it all. If you keep this framework in mind, you're not only going to crush your O-caps, but you will literally save your patient's sight. But as you master these traditional landmarks, I want to leave you with this thought. With the rapid rise of AI-driven fundus screening and next-generation longer-lasting anti-VEGF implants hitting the market, will the 4-2-to-1 rule eventually become a relic of the past, or is it going to remain the gold standard of clinical judgment? Thanks for joining me for this explainer. See you on the wards.